This episode of the Powering Through podcast is brought to you by NCHS, National Cornerstone Healthcare Services, a subsidiary of NCHS Holdings. NCHS is a full-service healthcare organization which, through its affiliates, includes an accredited specialty pharmacy founded to serve people with hemophilia and other blood disorders and to optimize patient quality of life by providing personalized healthcare services in addition to pharmacy services. NCHS makes independence the goal for people living with chronic disorders. They believe the home or an alternate non-clinical setting is the best place to receive treatments, which is why they do much more than just fill prescriptions. Patients of NCHS can also expect medication therapy management, coordination of nursing services, and much more, including translation services for non-English speakers. Learn more about NCHS services and the team who provides them by visiting nchswecare.com. Once again, that's nchswecare.com.
Hello and welcome to the Powering Through podcast, featuring panel conversations on obstacles, challenges, and what it takes to overcome, held for the benefit of the bleeding disorders community. The Powering Through podcast is sponsored by NCHS, produced by BloodStream Media, and I am your host, Heather Robb. You can subscribe to the Powering Through podcast on iTunes, Spotify, or wherever you listen to podcasts to have the most recent episode delivered directly to you. And visit poweringthrough.org to see videos, photos, and other podcast episodes from all of our Powering Through events. In this episode, we give a listen to our Powering Through event held during the New England Hemophilia Association's FallFest. Our participants were professionals from the healthcare industry, Dr. Jonathan Bernstein, Dr. Stacy Croteau, Emily Bisson, and Kaitlin Montcrief. The host of the Powering Through panel is Patrick James Lynch. We start our conversation with Dr. Bernstein, who works at the Connecticut Children's Medical Center and the Yale Hemophilia Treatment Center. So let's take a listen to our New England Hemophilia Association's Powering Through, starting with Dr. Jonathan Bernstein.
Hi, my name is John Bernstein. I'm at Connecticut Children's Medical Center and also at UConn. I basically got started, actually probably when I was following my father around as a pediatric orthopedic surgeon at Children's Hospital of Los Angeles. Some of the patients he would see would be some of the patients with hemophilia at the time. So I worked with him, then worked with Jonathan Goldsmith and Amy Shapiro when I was in fellowship. Since that, I've been 20 years now in Nevada and then just moved out to Connecticut about 6 months ago to co-PI the Hemophilia Treatment Center there.
Next up, we hear from Dr. Stacy Croteau, who directs the pediatric program at Boston Children's Hospital and is the associate director of the Boston Hemophilia Center. Let's jump back in and hear from Dr. Croteau.
I'm Stacy Croteau. I'm centered at Boston Children's Hospital and the Boston Hemophilia Center. So I direct the pediatric program at the Children's Hospital and I'm the associate director at the larger Boston Hemophilia Center. Like all good stories in medicine, I suppose my foray into hemophilia really started with a patient, actually in vascular anomalies, so in problems with development of blood vessels, arteries, and veins. A lot of those patients actually have challenges with coagulation and platelets, and that was really my scientific and clinical research interest. And then I met Dr. Neufeld, and so he pulled me into the Hemophilia Center, and I guess the rest was history.
Then we hear from Emily Bisson, who was inspired to become a hematologist after working as a counselor at H.H. Ranch and is currently at Yale's Hemophilia Treatment Center. Here's Emily.
I'm a pediatric nurse practitioner and have been at the HTC at Yale in New Haven for 6 years now. I first encountered hemophilia at camp, so I was a counselor at H Ranch, which I know probably is familiar to some folks in this room, and had some kiddos with inherited bleeding disorders in my cabins. And that was really interesting. That was before I decided to become a nurse. And then I worked in pediatric oncology, and so many of you are also probably familiar with the close network between hematology and oncology and pediatrics. So I got some exposure that way and have really, really enjoyed working with this community.
Lastly, we hear from Kaitlin Montcrief, who's a pediatric nurse practitioner and hematologist in Rhode Island.
I'm Kaitlin Montcrief. I am the pediatric nurse practitioner and director at the Rhode Island Hemophilia program. And I got into hemophilia about 6 years ago. I had a niece who had a neuroblastoma as a child that I went to a lot of her pediatric oncology visits and really thought that that's what I wanted to do, get into pediatric oncology, and worked as an adult oncology nurse to learn about all the chemo. And when I became a nurse practitioner, there was two hemophilia NP positions opening in Boston and Rhode Island, and I figured hemophilia, hematology, oncology, I could do some oncology, and I started doing oncology and hematology, and then once entrenched in the hemophilia community, I became passionate about it, and I've been with hemophilia alone for the last 6 years, and I love it.
There's something about those claws. Like, once you're in, people really don't leave. Now, we do have trouble getting clinicians in, and that is something maybe we'll come back to later, and we have to strategize how we can do that better, but it does seem like once we get them, we get them. What are some of the trends that we have noticed? What are some of the meaningful steps forward? I don't think we've had any what we might call leapfrog moments forward in terms of treatment advancements in the last year or two, but that might not be a perspective that's shared by everyone. So maybe Dr. Croteau, if you want to kick us off, what are some of the things in the last year or two that you've noticed that are worth underscoring?
Individualization. I think that best characterizes it. More and more, we're really focusing on what are the goals, what are the needs of this individual patient, and how does our current repertoire of factor concentrates and other therapies allow us to best meet the needs. So is it a patient with challenging joints who needs frequent infusion? Is it a patient who's really active and out on the ski slopes, out on the soccer field, out on the basketball court, who we don't want to just do every other day or twice a week without thinking through very specifically what does this patient need?
I think there's been a big focus on pharmacokinetics and PK, which I know is big in Boston, and we both participate in the WAPS hemo trial, where you can really get a better idea of how long factor is lasting in an individual to be able to cater their own prophylactic regimen and adjusting based on activity and stuff like that.
So we talk about prophylaxis now very casually in a way, because it is the standard of care, and it's about how do you individualize the prophylaxis, almost taking for granted that prophylaxis is in place. Emily, we were talking about particularly with some of the older generation, those of us in our, I say older, but like, mid-30s and older really, but those who did not grow up with prophylaxis, it can be more challenging for them to adopt to it. Can you speak to what you've seen with the adult patients when it comes to prophylaxis?
Number one, I really appreciate when they share their perspective and their experiences, but it's also interesting to talk with them about, what do you want your care to look like now, and how can we best make this fit your life currently. Some of them, I've heard comments of, save that for the kids. They're very genuine in their wanting to make sure that things are better for the younger kids. But we have a conversation about there's not a product shortage, and I really want to optimize your life too. I would say the vast majority of our adult patients, sort of when they've thought about it and given it, took some time and sort of researched it, if they've been willing to try routine infusions, they have come away feeling like they have a lot more control over their life, and it takes away a lot of the uncertainty that I think they just had decided was part of living with hemophilia, because it was just sort of like, it wasn't whether you were going to bleed, it was just when that next bleed was going to happen.
Yeah, we've really had a similar experience where a lot of our adult patients who are hesitant to start on prophylaxis, once they gave it a 1 or 2 month trial, said, gosh, I actually feel a lot better. There were aches and pains that I didn't associate with my hemophilia or bleeding that seemed to have gone away. And actually I think I'm infusing a little bit less than I was doing when I was just treating on my bleeds. So it's a very different mind shift for them, but we've had a similar experience.
And I think there's sometimes a hesitation that it's like, I don't want to commit to this. It's a time burden, it's a financial issue. But when we look at it retrospectively with them, we sit down after whatever we agreed to try it out for, it fits into their life a lot better because, again, it takes away the uncertainty.
It almost sounds like, in a way, that some of the activities of daily life or the psychosocial ease that can come with a predictable preventative regimen isn't necessarily fully appreciated before the individual starts. You get stuck, and I get this way too about my own care. You get stuck in just wanting to protect what it is that you're able to do without thinking through, well, maybe if I did shift in this way, it might open up more things I can do. It does feel a little risky to open that door. Dr. Bernstein, can you share a little bit of your perspective on the treatment and management of inhibitors and how studies like the SIPET study or any other work that's been done in the recent past has influenced the way you're thinking about inhibitors?
Basically, since the SIPET study is ongoing, before I would talk to the patients, even at the beginning, about the possibility of using a plasma-based factor, and there was never a taker from that point of view. After the SIPET study, now I have patients coming to us asking to go on plasma from the beginning. We always go through all of the risks from that point of view that may be occurring, things that have happened in the past that may still be a risk sometime in the future. But we seem to be having a larger number of patients that seem to be looking at plasma as a possibility, at least for the first 50 or so doses.
Dr. Croteau, what is your experience been? Similar to that with patients?
Sure. So I think the important thing about SIPET is it was a comparison between a group of plasma-derived products compared to recombinant products that had been around for a couple of generations. So it is important to recognize that all the newest products coming to the market, we don't have data yet on the inhibitor risk in POPs. But we changed our conversation as well. While pre-SIPET, we did not routinely incorporate conversations about plasma-derived products for our youngest patients. Now it's something that I talk about with all of my previously untreated patients.
And what about from your standpoint, Emily or Caitlin? I spoke with each of you about some of the challenges with how to educate patients in a way that isn't frightening or overwhelming. How do you filter through and navigate ways to have conversations about treatment, product, and choice with your patients?
So I think touching on the inhibitor conversation too, that's probably one of the most challenging conversations to have because you want to be educating parents when they're coming in with a newborn, because when are they at the highest risk for inhibitor? It's in those first 20 exposure days or so. But you don't want to scare them. And it's a really hard balancing act between making sure people are educated and know about the risk for inhibitors and know about SIPET, which is hard to not get too scientific, but in a simple way explaining the risks that are there.
You're asking people to make a decision that we don't necessarily have the right answer for either. I think it's hard because there's a lot of information to synthesize. There's a lot of unknowns. I mean, if we could really tell you who is at risk for an inhibitor, it would make these choices easier. And I can't imagine what it's like to be a parent having to make this decision, because I'm not really sure that there's a right decision for anybody, but I think you have to make the best decision for yourself, your child, your family in that moment. And it's hard because you're getting hit with a load of new info and you're in shock. And now we're asking you to pick a treatment product so that, we give you the right one when we give it to you.
We'll jump back in right after this quick word from our sponsor.
You've heard from NCHS about the services they provide to their patients. Now they'd like you to meet one of those patients. Joe. When Joe first moved to St. Louis, it was a bit of a shock. It's a big city, he was looking for a job. He didn't have much time to try to figure out his new insurance policy or figure out how he'd continue to receive his factor. Joe made a call to an NCHS rep he met at a conference, Kara, and Kara helped Joe get his coverage and his care in order. She ordered Joe's factor and made sure it got to him on the same day every month. She'd call to make sure everything arrived in order and check in on him periodically to make sure that he was keeping up with his care. Kara works for NCHS, the specialty pharmacy and healthcare organization, and this is what she does. She takes some of the hassle out of everyday life with a bleeding disorder. So Joe is able to focus on self-care without having to spend hours on the phone with doctors, pharmacies, or insurers. His factor and supplies showed up on time every month in the right quantities, and if there was ever a problem, he could call Kara. She just made life easier. NCHS. We care for life. So this seems like a natural point as well to talk about where we are now and products that are coming out and new therapies, these disruptive therapies. And there's two that we talk about kind of most often. And maybe Dr. Croteau, I'll kind of set you up to speak to these two trials. There's the trial for emicizumab, formerly known as ACE910, and there's the trial for fitusiran. And both of these investigational therapies, I believe is the correct terminology, are well under in their clinical trials, and they are both what are considered non-factor replacement therapies. So forms of treating hemophilia that are neither designed to replace the factor with either plasma-based product or recombinant based product, but not worrying about really factor at all, which is a paradigm shift in thinking. How should we be thinking about what these particular clinical trials mean for our community? Because it is very exciting, especially for those families that have inhibitors and the burden that is on a family. And yet we have to balance that with the fact that these are still investigational and we're learning as we go with these products. So how should we as a community be thinking about them right now?
I think what makes people very excited about these new therapies is they hear words like subcutaneous, no more IV. They hear things like infusion frequencies of once a week or once a month. I think they offer potential benefit also to our non-inhibitor patients, but because of some of the challenges with lab assays, with use with other factor products, it requires a lot more forethought and the need for really knowledgeable investigators, knowledgeable providers, and good communication between you and your hemophilia team. A little bit different from the, I have a bleed, I know my dose, I'm just gonna treat when I want, how much I want. Whenever you're on an investigational agent or even a newly approved agent, especially ones that work very differently from what you're used to, it requires a lot more communication.
Dr. Bernstein, in terms of the treatment of inhibitor patients in general, as Dr. Croteau just said, we don't really have a great strategy. There's a huge need there, which is part of the reason for the excitement. But you had also shared with me some of the work that you're aware of and following when it comes to treating patients with inhibitors, which was unfamiliar to me. So I was wondering if you could share a little bit about that.
There are one, there's a study that's ongoing with UC Davis right now that's looking at just using the 200 unit per kilogram dosing. There's also a couple of studies over in Europe that have used 200 spread over 2 doses per day, which people would think would be a little bit hard, but I've had 20 of my patients go through it that way over where I was at before. And 19 of them have gotten rid of their inhibitor. One of them is around 1% to 2%. We're now starting to be able to get rid of inhibitors sometimes up to around 70-80% pretty easily if we try things. And some it may be trying things different ways. And it may be we start off with a once a day type of treatment, but twice a day may actually end up improving things or even changing types of factor.
I think you make a good point. There's so many considerations with inhibitor patients. Sort of one modality is bleed treatment and bleed prevention. And when you have that inhibitor present, how do we prevent you from getting bleeds, or how do we effectively treat the bleeds when they occur? And then the other piece is how do we either prevent or how do we manage the inhibitor? How do we try to get rid of the inhibitor once it emerges? And I agree, there's a lot of good studies looking at changes in doses, changes in dose frequency, looking at our newer factor products that were more recently licensed. In fact, some of these extended half-life factor products that have these different moieties, these different components added to the factor 8, or in some cases factor 9 products, and how does that change the way the immune system sees those factors, and does that make them more likely to cause inhibitors or make inhibitors harder to get rid of? Or does it make no difference? Or does it actually make inhibitors faster to get rid of or more likely to be successful to be tolerized? And so those are studies like Dr. Bernstein is running and are available across the country that we're investigating.
Caitlin and Emily, how do you kind of frame what clinical trials are, the promise and excitement, and balance that with, the cautious optimism that seems appropriate given that we are still in trial phase?
If your current therapy is working for you, keeping informed and asking questions about these new products is great. But you don't need to feel like you're not doing the right thing by not jumping on a clinical trial. I think it's really important to ask questions and understand what that trial is going to, first of all, what that trial is looking at, because if it's an early stage trial, they're just looking at safety. They're not even looking at necessarily efficacy, but also what that's going to entail for your family in terms of commitment to study visits and learning about new treatment approaches as you go. You can't just do things as you've been doing them.
The good thing about it, so despite us not having any clinical trials open at our center right now, Dr. Croteau emailed me about 3 weeks ago, just to say, as a heads up, if you have any patients that would be eligible for this study, we do have it enrolled. We're right next door to Boston. Rhode Island's a very small state that our patients could potentially go up there, and I think that's a great part of being in New England is we have such a collaborative group of providers within these states, and we all email each other, call each other with anything. So it doesn't mean that just because a center doesn't offer a clinical trial doesn't mean that you couldn't necessarily enroll in one if you wanted to be.
We have seen in the last year or two some treatment advancements, but I think particularly notable advancements in awareness, education, and resources for people with von Willebrand disease. Dr. Bernstein, can you give us a little bit of a state of the union of von Willebrand disease in fall 2017?
We're trying to get out enough information out to other doctors and to people that may have a bleeding disorder so that they can go and ask the right questions and get to the right places.
I think it's something like 14, 15 years on average in that ballpark for a diagnosis to be made of someone that has von Willebrand disease. And you had also mentioned to me that there's a decent amount of misdiagnosing as having von Willebrand disease when it may be a platelet or other kind of bleeding clotting disorder. Can you speak a little bit more to that?
From that point of view, often we go with the easiest way to try to get a diagnosis, and sometimes our tests that we have are not always the best. One of those things, we do a test called aristocetin cofactor, which at one point in time was the state of the art, but it sometimes misdiagnoses patients, in particular with a disease called type 2M. So at one point in time, we suddenly were starting to see a large number of patients that were being diagnosed with type 2M, but didn't act like them. And it turns out the docs at a number of institutions, but blood centers of southeast Wisconsin, were able to prove that were a particular type of genes where they were only able to find the abnormality in the test tube, but not in the person. So meaning those people didn't have increased bleeding. They just happened on testing, or at least not from their von Willebrands that they were being diagnosed with, but actually may have had a different disorder ongoing. So it may be that we need to take the different types of looks at it, including perhaps doing the genetics of your particular disease, which is possible with both type 2 and 3.
So I think recognition and diagnosis are really the cornerstones of where we're trying to make improvements for von Willebrand disease. And it's true, we haven't done much with innovation in therapies for von Willebrand disease, but we may be able to piggyback on some of the innovations in hemophilia and potentially apply that to von Willebrand disease. I think part of the challenge, and Dr. Bernstein illustrated this really nicely, is the heterogeneity or the variety of what we see in terms of symptoms, severity, and bleeding types within von Willebrand disease. So even though people get labeled with von Willebrand disease, or even some of the specific subtypes, there's a lot of range of what patients experience within each of those types, and certainly under the big umbrella of von Willebrand disease. So it's not as easy as just lumping people together and doing a study or being innovative. Because of the frequency of von Willebrand disease, sometimes I've seen patients come to me or second opinions where just because people fell under the normal range by a percentage or two, people said, oh yes, you have von Willebrand disease, because it's common and labs are a little bit abnormal. But really when we dig a little bit deeper, we find out, no, von Willebrand disease isn't really your problem. It's a platelet disorder, or it's another coagulation type defect. So kind of delving in and making sure we have a good understanding.
How do you navigate those conversations with patients who come in and they're trying to acquire tools, they're trying to find ways to improve their life, but with all these variables, how do you navigate that with them?
It is a challenge. There's often a big delay. You talked about the delay in diagnosis, but even once what I find is patients come to see us and they have been if they have a bleeding disorder diagnosis because they have bleeding symptoms, or they need to get worked up for a bleeding disorder diagnosis because they have bleeding symptoms. They've often been struggling with those symptoms for a long time, and they may have been through multiple providers before they managed to get a referral to see us. And they may have tried multiple medications or been given various diagnoses. It takes us a while to make a diagnosis, and I know that we contribute to that frustration. But I think that trying to help them work with everyone involved in coming up with an individual plan to address those specific bleeding concerns is the most important piece. And trying to help patients and families understand that it may take us a little bit of time to sort of nail this down in terms of getting you a diagnosis that's really specific. And we may have to try several different approaches and utilize our colleagues. So for our teenage girls who come in with heavy periods, we're utilizing our GYN colleagues as well. and we all need to work together, and we need to just sort of stay committed to trying a treatment regimen, giving it a good shot, and then being open and honest about whether it's helpful or not. Because we can try something else, but I don't know that I need to try something else if you don't share that information with me.
You mentioned girls coming in with heavy periods, which I'm going to use as the opportunity to say, if you or someone you love is having a period that goes on for 2, 3, 4 weeks, that's not normal. And one thing that seems to come up a lot is that in families, if the women in that family are accustomed to having a heavy period, it just becomes normalized as, well, that's just us. We talk about these clinical challenges, but then there's also the cultural and familial challenges. If there is just a line of thinking in a certain household, we hear this a lot in Southern California. We talk about some of the challenges with a strong Latino community in Southern California, and there is a certain amount of, you just don't talk about your problems, you got to be tough. That's a cultural familial challenge that, is really hard to combat within the clinic. And I think within families, and we heard this so much doing the work for the podcast, within families where it's just accepted, hey, this is just who we are, I imagine as clinicians, that's almost got to be mind-bogglingly bang your head against the wall, frustrating. And with that, I'll let you all respond.
It's common how many new referrals that I've seen that I end up referring the parents to the adult side, that I'll do a screening test for them because they're like, oh yeah, I had a hysterectomy after my second child, or I had endometriosis and I didn't realize that my periods were always lasting 2 or 3 weeks at a time, and that we end up uncovering because their kid has von Willebrand disease, that the mom as well.
I think the thing I would add is that it's absolutely true. If you or your friends are having periods lasting 8 days or longer, I do believe that everyone with heavy menstrual bleeding should be evaluated for a bleeding disorder. However, it is very important to remember that there are actually many, many things more common than bleeding disorders that cause heavy and prolonged menses. And so if you have negative laboratory panels, that does not mean you are doomed to have heavy periods for the rest of your lives, nor does that mean that's where your evaluation should stop. And sometimes people get unlucky and can have a bleeding disorder plus something else that also causes heavy menstrual bleeding coming together. So don't be frustrated, or don't hold on too tightly to if I have heavy menstrual bleeding, it must be a bleeding disorder. It's important to think about that there's actually a spectrum of things that need to be considered.
What is ending up happening over the country is that we're now starting to see that many of the HTCs are actually partnering with the OBGYNs, with the endocrinologists, to have combination clinics for patients who do come in, so that we can get to the correct answer. Because it may be something that's an abnormality, that's a bleeding disorder, but it can be something that's a hormonal disorder, or something that may be just an anatomic disorder. And we're seeing, I think, probably about a quarter of the hemophilia treatment centers have already started to develop, or are in the midst of developing it. I'm guessing by another 5 to 10 years it'll be the standard.
And I was going to say the same thing goes for nosebleeds, that not
Yes.
all nosebleeds are a bleeding disorder too, and we have to collaborate a lot with our ear, nose, and throat physicians and providers just to determine it's not necessarily a bleeding disorder just because people are having frequent nosebleeds as well.
And the last topic that I do want to spend a little time on is gene therapy, gene editing, gene splicing. So in addition to hearing about these non-factor replacement therapies, we talked about those earlier, the other big disruptive leapfrog treatment thing on the horizon is gene therapy. We have, I think there's over 500 or about 500 gene therapy products that are in clinical trials. But when you think about gene therapy and its role in our, we've been hearing about it in the community for a very long time. I still have some newspaper clipping about gene therapy will cure hemophilia by 1999. That didn't work out. But these things, as we talked about earlier, do take time, and you need to do the due diligence and make sure that before it comes to patients that as much of the due diligence as possible has been done. But when thinking about the future of the practice, and maybe we'll kind of go down the line starting with you, Dr. Bernstein, what do you see that as doing for our community in the near term?
In the end, it's going to be the primary treatment for many diseases from that point. But we're still a ways away from it. With hemophilia, as one disease, we may be on the brink, at least, for it to be able to treat and possibly to cure the disease. But there's still questions down the line as to what's going to happen. What's going to happen in a patient if a gene goes into the wrong place? We should be able to cure those things in the future if we can cure it for hemophilia from that point of view. and is steadily going to improve over the next 5, 10, 15 years. I would expect that on a general purpose type of thing, that you're probably going to be able to provide one form of gene therapy within the next 10 years.
So I agree. I think gene therapy in a lot of ways is simple, it's elegant. You're just teaching the body how to make the factor protein that it does not currently know how to make. If only science were that easy. So the nice thing about gene therapy is if you can teach the body to make the protein, then some of the other things that I mentioned with the disruptive therapies about challenges with assays and how does it work with factor product, right, those things sort of go away because it's the same protein. So that's really exciting. I think the challenge right now is how do we actually get the genes into the right cells? How do we get the cells making enough of those proteins? So I think we have a lot of work to do to sort of titrate and get to the right target levels with gene therapy. And then is true with all of our investigational therapies, thinking about the safety component. Where is the gene going? Where are these virus particles going? What does it mean for long-term health and long-term cell health? What does it mean for the immune system to see this new factor 8 or 9 and these viral particles? How long is it going to last? So I think we're as close as we've ever been to really seeing success in the body cranking out factors, but a lot of these other seemingly trivial in some ways from a non-scientific perspective, some of these other factors actually are going to likely be the barriers that get it through clinical trials and get it widespreadly available throughout the hemophilia community.
The big question that everyone asks and is thinking about with all of this gene therapy is the cost and what's going to happen down the line of how much does it cost a hemophilia patient per year for their factor, and then how is that going to be priced down the line once it is approved and it's an option for treatment, which is something that always comes up when we talk about gene therapy as a potential in the future.
And what's your general answer to that question?
I don't know. To be determined.
I think that's the honest answer, right? That's one of the known unknowns of where we are at in the process.
Thanks again to Dr. Bernstein, Dr. Croteau, Emily, and Caitlin for participating in Powering Through. And thanks as well to the board and leadership at the New England Hemophilia Association for hosting our panel. I'll be right back with smart people saying smart things after this final word from our sponsor.
NCHS believes in being a proactive partner in their patients' care, which means providing services like arranging convenient and discreet delivery, encouraging adherence to therapies, and monitoring your therapy outcomes. They also provide reimbursement services to help with navigating insurance requirements, which can be overwhelming for families affected by bleeding disorders or chronic disease. With a pharmacist available 24/7, NCHS can offer comfort to patients that someone will always be there when needed. Check out their website to learn more, nchswecare.com, or call 877-626-6247. Again, that's 877-626-6247.
Today's smart person is Helen Hayes, an American actress whose career spanned almost 80 years. She's one of only 12 people who have an EGOT, an Emmy, Grammy, Oscar, and Tony Award. Here's one of many smart things Helen said. We relish news of our heroes, forgetting that we are extraordinary to somebody too. And that will do it for this episode of the Powering Through podcast. Thank you for listening, and we'll be back next month with another episode featuring another great conversation. Remember to subscribe to the Powering Through podcast on iTunes, Spotify, or wherever it is you listen to podcasts. You can also stream our podcast episodes, watch videos of our conversations, and learn about upcoming Powering Through events by visiting poweringthrough.org. Many thanks to NCHS for sponsoring the Powering Through podcast. Learn more about NCHS and their services by visiting nchswecare.com, where you'll also find links to their Facebook and Twitter accounts. And you can learn more about all of BloodStream Media's podcasts for the bleeding disorders community by visiting bloodstreammedia.com. This episode of the Powering Through podcast was written by Heather Robb and Patrick James Lynch, produced and distributed by Patrick James Lynch, Joshua Sterling Bragg, Rob Bradford, Colby Crow, and Avra Friedman. Artwork created by Ryan Geelan and Katie Wright Mead, and the Powering Through podcast is edited by Allison Stoney. My name is Heather Robb, and until next time, take self-care of yourself.